provided by Eli Lilly and Company. The goal of this program is to introduce the participant to the recognition, diagnosis, and management of psychosis in long. Patricia T. is a 71-year-old resident recently admitted after a myocardial infarction. Almost from the first day, she has complained of vague abdominal pains. She is unshakably obsessed with the belief that she has abdominal malignancy and cannot entertain any possibility that her explanation for the pain she feels is incorrect. Patricia has lost 12 pounds since her admission to acute care. She has lost 7 of these pounds since being admitted to this long-term care facility. She has insomnia with early morning awakening. Her physician, recognizing her weight loss and knowing that a depressed mood can be a presenting sign of internal malignancy, has already performed a very thorough workup, including a CT scan of the abdomen with negative results. He now believes the resident may have another very serious medical condition, a major depression with mood-congruent psychotic features that presents with the commonly seen delusion that the resident has cancer.
Doctor, you're not listening to a word I say. I've got to have some help. My insides are rotting, I know. I think they're trying to poison me. So you've got to do something, maybe an x-ray, anything to help.
Patricia is beginning to intrude on other residents and visiting families, telling them that she has cancer, but that the nurses and doctors don't care. Patricia has been telephoning her son many times each day to complain that her physician and nurses aren't doing anything about her cancer. She has even telephoned other physicians to request examination. The physician orders the nursing staff to observe the resident's sleep pattern, how much the resident is eating at each meal, and to observe if Patricia has periods of crying. The physician also orders administration of a geriatric depression scale which scores strongly positive. With target symptoms identified by the nursing staff and the depression scale roughly determining severity of depression, the physician considers the treatment options. He may order an antidepressant alone, with the expectation that for about 1/3 of such residents, once the depression is improved, the psychotic features will simultaneously resolve. Or he may treat with both an antidepressant and an antipsychotic. Due to the severity of Patricia's symptoms, he opts for combination therapy, which is typically successful for 70% of such patients. In an interview with the resident's son to explain risks and benefits of treatment, the physician is surprised to learn that Patricia had similar problems many years ago when menopausal. At that time, she was successfully treated with imipramine and thioridazine. The physician is concerned that both drugs have anticholinergic activity. At Patricia's age, she is more susceptible to anticholinergic side effects than in the past. He elects to use fluoxetine for antidepressant treatment. Both the resident and son express faith in thioridazine, and since this drug is an appetite stimulant and has sedative properties, these side effects may actually be therapeutic. Though newer atypical drugs have substantially lower risk of movement disorder, the physician believes that Patricia will likely require only low doses and be treated for a relatively short time. Taking all factors into consideration, the physician decides to use this previously successful treatment. The physician advises the nursing staff to observe for side effects, especially postural hypotension or movement disorders.
Well, it's been almost 4 weeks now. How is Mrs. T doing today?
She's less depressed at this time. She sleeps better at nights. She gained a little weight, and she's less obsessed of having cancer.
I-23.
The physician recognizes that Patricia's psychotic features have resolved and plans to taper and discontinue thioridazine. He will continue with fluoxetine for approximately 8 months if her depression continues to improve. The physician instructed nursing staff to continue to watch for drug-induced Parkinsonian and other motor symptoms as thioridazine is withdrawn. While the pharmacologic properties of antipsychotic drugs are of great importance to choice of treatment, past successes and the beliefs of residents and family should also be considered. At the heart of successful treatment is the explanation of benefit and risk of various treatment options so a sensible choice can be made. In this case, the physician successfully treated with an antipsychotic medication that from a purely risk and benefit standpoint was not the best choice.